magnitude and their own responsibility in the change that's coming. So, to provide forums and opportunities for employees, staff to understand what's going to be different, the new responsibilities we have, the new requirements in the new marketplace, and better ways and more efficient ways to take care of patients. So that education piece is pretty critical. Formal change management support as you go through the transition is essential. But I think the orienting folks throughout the environment to reality of change is pretty critical, and focusing the support activities in the areas that are affected. So when the medical home was rolled out in our organization, after the appropriate development period, it was rolled out across the entire primary care space. So not in certain areas, but the whole organization changed. So there was consistency in approach, and wherever folks might work, they found themselves in the same set of circumstances. I do think one of the hallmarks of this organization, wired into the DNA of the Cleveland Clinic, is a commitment to innovation. And so I think we view the transition and the need for transformation as a tremendous opportunity. And I think folks here are energized by the opportunity to deliver care in different ways and to provide different venues and different and more efficient methods for taking care of patients. And that has a lot of implications and translates itself into a lot of aspects of how this organization is set up. Even for employees and our own benefits, we've seen a pretty dramatic change in orientation around wellness and individual responsibility to improve your own health and manage your own health effectively, which creates an environment and atmosphere focused on doing the right things and assuming personal accountability. I will tell you that you can walk from one end of the Cleveland Clinic to the other, and you will not find a Snicker bar in any vending machine. So good luck. So, but the whole environment reinforces, the change in the healthcare delivery system. So, important to do it consistently across the board, provide the appropriate training and support to orient people to what's coming down.
Thank you. I'm going to ask this of the panel so anyone can answer this. But the central goals of health reform are better health, better care, lower costs. Looking out over the next 5 to 10 years, if we stay our current course, do you think we'll achieve these goals? And let me also go forward and ask you, what strategy do you think has the most promise?
So that's a great question, and I think we have no option but to make
Sure. Put the microphone right away.
If that happens. If you take a look at our website, you'll see that we're moving the needle in Northeast Ohio on all three of those fronts: better care, better health, and lower costs. And we would love to see that go to scale. If we can build on that work that's occurring, we will definitely see in 5 to 10 years a large significant impact. So far, due to our collaborative model of membership and the amount of providers, many of you here today that are participating in that, we have 143,000 patients in Northeast Ohio represented in our database. We've touched about 70% of the individuals living in Cuyahoga County who have chronic disease, diabetes, hypertension, and high blood pressure. And I'm happy to report that 69% of those diabetic patients in that data set are demonstrating good blood glucose control. That's A1Cs of less than 8. We're demonstrating 71% of the hypertensive patients maintaining a blood pressure of less than 140/90. This is significantly improved from over the past several years from where we started. And the fact that we can measure that data because people are willing to give it to us so we can see as a region where we are. We've also compared the quality of care in managing diabetes and high blood pressure to national benchmarks. This processes of care coming out of our healthcare organizations. And I can tell you we've exceeded the national benchmarks on all fronts for both insured, Medicaid, Medicare, commercial, and uninsured populations. So much of this is in part to the collaboration, the partnership, the learning collaboratives that you've attended, the multi-stakeholder convening, looking at data, working with coaches, getting NCQA recognized. It's all due to those efforts. And finally, on the cost front, although it's early, we just submitted an abstract actually to the Governor's Office of Health Transformation, which showed that between 2009 and 2011, approximately 2,200 ambulatory care sensitive condition hospitalizations were averted in Cuyahoga County during that time period, saving about $13 million in cost. This means that conditions that we knew could be managed by primary care were in fact managed that way, rather than these people showing up in the emergency room and being hospitalized. So although early, there is a white paper being written right now, so more to come on that. But with those early results, I would hope, and now with the state behind this type of work and the collaboration at the state level of leadership there, I expect we'll be verified.
I was really encouraged when Greg Moody talked about how this is a time for us to really be creative, and this is a good time to be working in the system. So in reaction to what will happen in the next 5 years, thank goodness we're working on value and not just units of service. Thank goodness we're taking a look at those who have the most difficult needs and have the highest cost of service. And if we can really focus on the sickest of the sick, and if we can then strategize in a creative way, so many of the things that we know that work. One of the frustrations I had working in the system was we knew what worked. We weren't paid to do it. We were paid to do the things that we were paid to do. We did those. And now that we are able to take a look at what are the things that are going to move the needle and help people recover, become more healthy, and be a part of creating that and have some freedom to do that, innovation to do that, then there's hope that we can take some of the things that work the best and scale them up. And one of the things as a private funder who looks at ways to fund the cutting edge ideas, let's say, and find things that work well. For example, we're taking a hard look at how many people with mental illness are being incarcerated, and it really has become an epidemic. Instead of treating them, we're incarcerating them. And so we entered into a partnership with the Woodruff Foundation to do a work with mental health on helping those folks who are incarcerated in the jails that have mental illness and helping them get connected to recovery resources and Murtis Taylor and to a healthcare clinic. And we're working on how do we even work together? How do we create that transformational system? And if we can demonstrate things that work well in these partnerships and then work with government to take those things that we learn and then scale them up so that they can be used around the state, and I think that's part of the process that I've seen that has been very encouraging, that we take some things that really work and we work on them in a focused way. We work out some of the bugs. We create systems that support those innovative practices. Then we can start moving the needle on the actual issues that people face in their lives when they're struggling with these illnesses.
So we're probably unanimous on this. I don't think the nation can afford to go Ohio unfortunately. And the focus on the payment system is absolutely critical because, one aspect of the healthcare system most needs to change is the way caregivers are paid for the care they provide and deliver. And so, these areas that have great opportunity to enhance coordination, enhance the capability of working together, also require changes in the way we're paid in order to provide the ability to do things that are needed that aren't covered in the current payment system. So, we think about assuming responsibility for the health of the population, then being paid for care coordination, being incentivized to improve outcomes. is a radical change from the way caregivers are paid today, and that's what's essential to driving the agenda forward in the future. The other thing that I think is important in relation to payment is to the extent that we are able to reduce what we spend on healthcare, and employers and individuals either are healthier, more productive, and able to participate in the workforce. Employers can devote fewer resources to healthcare and more resources to other aspects of their own business. There's an opportunity for economic growth and to drive improved economic performance. And so that this part of Ohio could be a beacon for employers to locate here, because if you can provide better health outcomes at a lower cost, then you have a healthy, productive workforce that's a powerful engine for economic growth. And so I think we've got a real obligation and opportunity to continue to work in this space to improve it.
Thank you. And please feel free if anyone would like to ask a question. I've got a couple people with microphones. They'll come around. I'm going to ask one question before we open it up. Greg brought up poverty, and I hope that that means that we're going to see an equally ambitious set of strategies around solving poverty in Ohio. But the one thing I formerly worked for the health plans and constantly heard is that you cannot focus on somebody's health issue if their basic needs aren't being met. You have to address those before you can move on. Can you talk about, certainly you've all dealt with the implications of poverty and the consumers that you've worked with. What are the greatest areas that you think, or the biggest challenges that you've seen?